So we're starting this session on acute encephalitis syndrome. And we have a very distinguished panel here. You've already heard their names. On my right is Dr. Rautre. Okay, Dr. Rautre, so he's from PATH. Then we have Dr. Ming Lim from, he's a reader in pediatric neurology at King's Bath Partner Center, UK. Okay, so I don't think I can read all this, but we can start anyway. So let's start with Dr. Ming. What are the differentials for a child presenting with acute encephalopathy and definition of acute encephalitis syndrome? So can we start with this?
Sure, thanks. So before we start, I think I'd like to take a few steps back and actually look at the diagnosis and definition of encephalopathy. And as you know, diagnosis and syndromes like this are defined on either constructs that you make as clinicians because we don't have pathological diagnosis, or syndromes that happen pretty commonly that you can use them to define clinical conditions. So firstly, encephalopathy, as you all know, is probably one of the most difficult symptoms to actually define. It's a bit like consciousness. There's actually no definition of consciousness. So by definition, encephalopathy is the brain not working, borrowed from the Greeks. To what extent does the brain not work? So simply, as pediatricians, we use behavioral change as inferred by being extra irritable, not being right. And I think importantly, we use it in the absence of fever, which is important. But if you have a fever encephalopathy, that might mean something else. And clearly, if you get older, the loss of consciousness can be added to the to the symptomatology. So an encephalopathy, just to highlight what Professor Nair says, in summary, is just a child that is not behaving well or not working, or the brain's not working well. Encephalitis then infers that there is an inflammatory, component to that. And you will read many reviews that encephalitis is a pathological diagnosis, but we can't do brain biopsies in everyone. So what we allow for is the diagnosis of an inflammation based on clinical grounds. So this is your focal neurology, your seizures, or what you can measure by what we call paraclinical features. And by that, we mean the CSF being reactive. We've heard today about how important some of those findings are: pleocytosis, proteins, glucose. Can we infer, changes in those? But also imaging, which is fast becoming a surrogate of clinical acumen, as we heard today, but nonetheless irreplaceable with some syndromes like inflammation. And then we sometimes use EEG as a marker of that. And then you can use other iterations to define the diagnosis depending on how strict you want it to be or how relaxed you want it to be. So that's the one thing I wanted to mention about diagnostic, criteria. And then the next question I think you should ask yourself is that, what are you setting up the diagnostic criteria for? Is it as a screen for clinical use, meaning you use that as a criteria to instruct on whether you start treatment or not? Or is it for scientific use, meaning that you want to collect a group of patients that is systematically corrected across all, the country or all nation in one particular study? And I think I will defer that to the later, experts who will tell us about, respective studies in terms of etiology in the country, because how rigorously you collect according to the definition may actually define the sort of conditions that you get. So simplistically, if you're looking for a condition, let's say NMDR encephalitis, if one was to use the definition to collect the patients, you are going to get patients that are only encephalopathic. You may not get the milder symptoms of patients or the spectrum of patients Vice versa, as you know, with a potent type syndrome like this, you may get different etiologies within there. So hence, the strength. So I'm going to stop there briefly, but I recognize that I have not answered the first remit, which is the differentials of acute encephalopathy. But for brevity, I think a lot of you as pediatricians, a lot of you practicing clinicians out there will know that the prime groups of presentations include the toxic encephalopathies, some are the epileptic encephalopathies, metabolic comprised of a big group of patients, some with neurometabolic conditions, and then the infective and the immune, where I'm sort of more I suppose qualified to sort of talk about. So I think that's from me.
Okay. Well, in India, we have a different kind of, you can actually classify the causes. So first of all, it would be infections. If you're talking about acute encephalitis syndrome, this is a term, which was brought up by WHO in 2006 after the very, very bad epidemic that we had in 2005. So after that, WHO coined this term for the purpose of JE surveillance, acute encephalitis syndrome. And so what they say is that it's an illness affecting a person of any age, at any time of the year, with presenting with acute onset of fever, with some alteration in consciousness, which could be in the form of disorientation, stupor, coma, etc., and or convulsions, but excluding simple febrile convulsions. Okay, so this is the WHO definition of acute encephalitis syndrome, but basically it means anybody, any child or any adult coming with fever and altered sensorium and or fever with convulsions. That's it. Okay? So that's the main thing. And we can call, so the most important causes are infectious. So they could be viral infections or non-viral infections. Then you can have, this inflammatory disorders of the brain, which are not infectious really, like ADEM, or you could have autoimmune encephalitis, or even SLE, affecting the brain. So things like that. And then you can have some infectious encephalopathies which affect the brain. Things like cerebral malaria, enteric encephalopathy, dengue encephalopathy and all. And then of course a whole lot of metabolic and structural causes, as you've just said. So many times you have things like toxins suddenly causing an epidemic-like situation in Bihar, things like that. So that's the Indian kind of way we look at it. And then, but you're very right about the, the distinction between encephalopathy and encephalitis, etc. Then Dr. Padmalochan, please, the next question is for you. Is anything you'd like to say?
Yeah, Dr. Biswal is not there, so I'll take up the questions on his behalf. So we just heard about, enigma of AES is AES not a disease. It's a symptomatic surveillance definition, which is caused by, we just heard from Madam Rashmi that it's, a host of array of infections starting from virus, fungus, bacteria, rickettsials, and a lot of, that's the challenge of AES actually. And in India, to just give you some figures, we have around 12 to 13,000 cases of AES reported in a year, and they come from, and 1/3 of that comes from Uttar Pradesh, which is the lion's share, of course, of AES, but it varies. Out of those all, there are 28 etiologies of AES that we have come to know in India, but most of them, there's a state variance here. Actually, what is the principal cause of AES in UP is not in Bihar. Bihar, we just heard it's the lychee toxin that was responsible. And you go to another state, it's quite different. Just to give you some numbers, out of that 12,000 cases, almost 4,000, one-third of cases is coming from 7 districts of Uttar Pradesh, which are highly endemic, high-risk areas. And I'm going to give those statistics from that area and that region so that you have an idea as to how does it look. It's 617 villages out there which we call as high risk in those 7 endemic districts of Gorakhpur and Basti division. And the gender divide is almost 50-50, 51% males, 49% females. It's not of a much of a divide there. It's equally distributed. When it comes to age distribution, it's almost, it's a childhood disease. It's a pediatrics age group that gets affected. 85% to be precise of the entire lot are from, up to 15 years of age. So that is something which is very cutting across the entire country. And then we have it's a seasonal variation. It's not all across the entire year. We get almost 80 to 90% of the cases in 1/3 of the months, starting July till October. So here we are in the middle of high transmission season right now. So it's actually in this period. It's a high transmission. It's a very seasonal pattern that we see in India. And that's where it's usually found. And giving you some more analytics that we have done. So it's predominantly coming from low socioeconomic strata. That's very clear in terms of analyzing, doing the analytics up to the socioeconomic profiles. They usually 80% of them are from rural background, agricultural background, and if you see their treatment patterns or treatment seeking behaviors, almost half, 50 to 60% of them initially goes to a non-formal, sort of a quack, semi-quashy, sort of practitioners, and they get held up actually. They get delayed, and it starts like high fever, and till you have altered sensorium or any mental disorders, we are in a very acute shortage of time to manage the case. It gives us around 72 hours to do all the interventions by the time it's quite late. So that's the greatest challenge. That's why the CFR is very high. The case fatality ratio is very high. So we have around, the statistics is something around 14 to 15% of children are dying out of total reported. So that's kind of a high CFR. And the entire enigma is to how do we intervene early and manage cases timely so that we can save lives. I think I'll stop there.
Yeah, I totally agree with you, Satyamrata, because what we find is that you have a child who has just developed fever. It's usually high fever. And after, say, about 20 hours or 30 hours or so, he has a fit, he has a tonic spasm, and he just goes into coma right from then on. And then that's the time when the parents want to bring him to the hospital. But being in such interior areas, by the time they get to a tertiary or even a secondary care hospital, it's almost too late. They're almost moribund when they arrive at the hospital. So this is a compact clinical course. I think that's a very big challenge in managing these patients, because before that they only have fever. So just high fever, people may not, rush to a health facility for that. Now, the next question is to Nivedita. Nivedita, from ICMR, what are the epidemiological studies on AES that have been conducted by ICMR in the recent past? Nivedita.
Yeah, so good afternoon, everybody. There are mainly two systems which are extensively working in India on AES surveillance. Of course, the Integrated Disease Surveillance Project, IDSP, Dr. Akash is here, and National Vector-Borne Disease Control Program. ICMR undertook some targeted studies in Gorakhpur division, because in Gorakhpur what happened is, as Dr. Rashmi just said, that in 2005 there was a major epidemic of AES, and after that, and there was the JE positivity was up to the tune of 30%. So the government of India introduced the JE vaccine in the year 2006 in all the endemic districts, and all the endemic districts in UP were covered. So over the years, next 3-4 years, we saw that the overall incidence of JE declined. It became as low as 6%, 8%, or not more than 10% in any of the year. But eventually, the number of cases of AES remained the same. And the definition of AES is so broad. It's fever with altered sensorium with fresh onset seizures. So eventually we realized that there are actually hundreds of infectious etiologies, be it viruses, be it bacteria, be it parasites, or even fungal infections, which get clubbed as AES. So then the worry becomes that in this clubbing, and then in general calling everything as Japanese encephalitis, we are also not treating the etiologies which could be treatable in early stages and the child could be saved. So ICMR undertook intense studies in Gorakhpur region, and with a mandate to find what is the etiology in the unknown cases of AES, which was in Gorakhpur in the year 2012 to the extent of 80%. We didn't know what is the etiology of AES in children who were admitted in BRD Medical College, Gorakhpur. And then we looked for enteroviruses because there was a lot of enteroviral circulation going on, and few earlier reports that enteroviruses could cause encephalitis. But we didn't find any enteroviral infection. And then in 2014, we got a clue that it could be a rickettsial infection. And then when we went on to investigate in BRD Medical College, we found that in 2014, almost 60% of the children were positive for scrub typhus. They were ELISA positive for scrub typhus, both in CSF as well as serum. So then we went back to the government and said that this is what we are finding, but then we were told to validate, because scrub typhus, this is a very atypical presentation. It never presents as AES as per the reports available and doesn't affect this age group. So we went on to do many detailed studies. In terms, we did a case control study. The cases which were getting admitted in BRD Medical College, we did their IgM ELISA, and then we compared it to their sibling controls who were negative. Then we also did almost 3 years of follow-up in the AES patients, and this positivity was there. And when we compared the samples and we tested the samples from Orissa and Bihar, we didn't find much positivity for scrub typhus in our archived samples. So this was peculiar for Gorakhpur only. Then we also went and did community level sero surveys, in which we did we did a sero survey in which we enrolled 1,200 individuals in each of the sero survey that we did. And we checked these individuals for the presence of IgM antibodies for scrub typhus, IgM as well as IgG. So the presence of IgG antibodies in both our sero surveys was to the extent of 70%. So this indicates that there is a transmission of scrub typhus that is going on in this region. Then we also went and tried, because the vector for scrub typhus is the sugar, larval mites, and which reside on the rodents. So we even did these entomological studies, and we found that the houses in Gorakhpur were infested with lot of rats, and in general language we call chuchundar. They stay in the kitchens. So we did entomological studies, and in these rodents we found positivity of scrub typhus. They were positive. They were multiplying scrub in their body, and the mite, when crushed and tested, also came out to be positive. So there was enough evidence for us to go and tell the government. And then we also did a study for acute febrile illness surveillance, because then our hypothesis were that when a child presents with fever, that is the time when you should test the child, and if he's scrub positive, then you should immediately start him with doxycycline or azithromycin. So if that stage the child is treated at the primary health center or the district level, then we can avert his mortality due to AES. And the other problem with this is that the definition now is so broad that if you look, even tubercular meningitis, bacterial meningitis cases are getting clubbed as AES. So we recently have developed a diagnostic algorithm for AES with the help of all partners, wherein we have requested the government to set up facilities for diagnosis at least of these treatable etiologies at the district level hospital, wherein we can prevent the infection from becoming severe and treat the children at the first point in contact. So, and in parallel, CDC also funds a global health security network which is run by NIMHANS. So they do AES surveillance in 3 states of the country, that is West Bengal, Assam and UP, in areas where we are not working. So they also have similar results. And as of now, we find that the top 3 causes of AES in India are, in fact, more than JE, now it is scrub typhus to the extent of 30 to 35% positivity. Then being Japanese encephalitis, staggering somewhere between 10 to 15%. And the third is dengue. Suddenly dengue is presenting as acute encephalitis syndrome. So my request to all the clinicians is that whenever you are looking into a patient of AES, please try and investigate the patient for this, at least for scrub typhus, because this is a treatable etiology. And with IV azithromycin and even minocycline, patients do improve. So this is one thing which should be definitely looked into. I'll just stop here.
Okay, thanks. Now, next question again to Lim. Lim, what are the clues towards etiology from history and examination?
Thank you.
Okay, sorry.
So I'm going to mirror what Professor Chevelle said earlier, that you really got to tailor what is happening locally. So my clinical examination and history is based on the etiology in the UK and in European countries. So to put things in perspective, if you take and this is based on 2 studies, one done in the UK, which is our health protection study, which is commonly quoted, and also a pediatric study that we were involved with Professor Dale in Australia, both tend to show that the herpes virus groups are the biggest cause of encephalitis as defined by what I said earlier, i.e. fever plus 2 extra features of encephalitis, either focal epilepsy, seizures, focal neurology, or CSF and or MRI changes. The other 20 or 30% is usually an autoimmune cause, be it ADEM or be it autoimmune encephalitis. And then the other 20-30% are sort of unknown. So hence our clinical examination and history taking is tailored to that. So to dissect out inflammation from infection, we tend to ask for a family history of autoimmunity. A lot of you will know that it is higher or more prevalent in certain community and certain ethnic group. So in Southeast Asia, where I come from, it is very, very prevalent. And again, making sure that you can actually operationalize a higher risk to that specific patient. So all you get is a good predictive value or a negative predictive value. It doesn't really tell you it's not a feature of the condition as such. But what I do think are features of autoimmune conditions like autoimmune encephalitis. One, I think it's psychiatric features right at the outset. The second is what we call polysymptomatic, and we might talk about this a little bit later in the NMDR encephalitis, where you get the coexistence of seizures, movement disorder, and psychiatric presentation at the same time. And I think thirdly, for me, in the history, you would look out for what we call a viral prodrome. So they'd had a viral illness a couple of weeks ago, and they had gotten better, and this is the second phase of the illness. And then when it comes to the infective etiologies itself, I think I would be the most ill-placed person to advise on this, knowing that your local milieu is entirely sort of different. But, in the UK, we would certainly take a very good travel history and then go and look up the books, what bugs actually been found there. And then taper your history to cold sores, etc., because of the HSV risk and because all those viruses that you're going to identify, that's the only treatment implication that can be different. So I'm going to actually hope that my colleagues, or perhaps Dr. Gupta, can tell us a little bit about the differentiation between the other viruses in the clinical examination. I mean, for us, we would then take a history of examine for the particular syndrome. So if you had a brainstem syndrome, you might think more about, a rhomboencephalitis, and hence those are the specific viruses. If it was a cerebellar syndrome, maybe VZV, but, one acknowledges that, the viruses can attack every and one part of the brain, as Professor Newton showed earlier, in terms of all the targets and the focality of the symptom. So, any other specific local bugs?
So I think Lim is giving us a very good, like a very good picture of the difference between the West and the East, actually. So he's talking about autoimmunity, factors which, or clues which could be obtained from the history and examination vis-a-vis autoimmunity, etc., and herpes and things like that. But what we find, I mean, as a clinician, I would say that what we find now in Lucknow or Uttar Pradesh, because we get our patients from Eastern Uttar Pradesh, not necessarily from Gorakhpur. But, like there are two distinct groups that we are seeing now. And one is a pure neurological type of syndrome, which is like JE. They come with only neurological problem, with, of course, fever, and they go on to have severe extrapyramidal features, etc. And herpes also is pure neurological. But you have another group, which is like dengue and rickettsia. Now, both of these, both dengue and rickettsia have low platelets. Okay, so that's a clue. Then they have a peculiar swelling on the body. That's found in dengue, but also in rickettsia. It's a kind of non-pitting edema that you see. Then you also have rash. So dengue, not in all cases, but pretty much, 50, 60% would have a rash, and so would rickettsia. Then, the abnormal liver function test. You don't have clinical jaundice, but you have raised liver enzymes. So something like 3 to 4 times normal. So, this kind of multi-system involvement, this goes towards dengue or rickettsia, and maybe even leptospira, because we are not really testing very routinely for leptospira yet. So I think, so it's such a big difference from what you see and what we see. Now, and then, like if there's anemia, then you think more of cerebral malaria. You start thinking in terms of cerebral malaria and splenomegaly. So anemia and splenomegaly would favor cerebral malaria, but you also have to consider where in the country you're coming from, where is the patient coming from. Is he coming from an endemic area for falciparum? That's important. And then, focal deficits, of course, if there's HSV, herpes simplex, you have high prevalence of focal deficits. But just remember that even Japanese encephalitis, there's a lot of focal deficits. And the focal deficits are a little different. They could have monoplegias, triplegias, hemiplegias, whereas in HSV, it's mostly a hemiplegia, that sort of thing. And a history of dog bite, of course, we always take. So travel, where is the patient coming from, what is the season, what is the age group, and all these factors. These things would, at least in where I come from. I don't think this holds true for many parts of the country. All the, even Chandigarh and all, it doesn't hold true. Okay. Then, mic, please. No one's got a mic. Speak. Okay.
responding because you mentioned Chandigarh.
Chandigarh.
Yeah, we just finished last 2 years ago when I was there. Study on CNS infections, meningoencephalitis of more than 400 consecutive cases with PCR and the usual testing, CSF and serum. And lo and behold, scrub typhus was the one which was maximum. And while, of course, you rightly said, I mean, many of them will have clues like, looking edematous, rash, low counts, etc. Not all of them would. But the fact is that it is so eminently treatable and not many people think about it.
Yeah.
So it's an important message.
And even
that needs to go.
the antimicrobial that you use is different. So one has to keep it in mind, otherwise you would not treat it. Okay, so now the next question is to Atin. Atin is from AIMS Radiology. So what are the clues towards etiology from the radiology, Atin?
So thank you, ma'am. Basically, what's the role of imaging? In any acute encephalitis, foremost is obviously clinical stabilization of the patient. So when imaging role comes in, when the patient gets stabilized, ideally it needs to be done with MR, because we all know MR is definitely best in picking up lesions. If MR is not available, sometimes CT can be used at that time. Actually, it's more required to maybe sometimes rule out hemorrhage rather than actually localizing the lesions, especially when you know very well lesions in the brainstem, cerebellum, they are not actually well picked up on CT, and very early lesions are definitely not picked up on CT. So if possible, if you are considering imaging, get a MR done. In terms of MR, since it has been discussed, there's a whole lot of around 26 etiologies which are fitting into acute encephalitis. All of them may have a very different type of picture. It's not specific picture in which you can label one thing as one based on many of these, but in some of the cases, radiology does give you a very diagnostic clue. Let's we talk about Japanese encephalitis. Again, the findings are not very specific, but typical locations of involvement of the thalami, bilateral thalami, asymmetric involvement with usually a swollen appearance, maybe with some hemorrhage in the initial stages, along with involvement of the brainstem in form of substantia nigra involvement and maybe some involvement of the basal ganglia bilaterally, would strongly support the diagnosis of Japanese encephalitis, especially if it is being clinically considered. Then maybe you can be on imaging, be sure that you are dealing with actually Japanese encephalitis. Almost same can be the picture with herpes. We all know it has got a very typical appearance on imaging, where especially the entire limbic system, the medial temporal lobes, the insular cortex, or the cingulate gyrus is involved symmetrically, maybe asymmetrically, even if on the one side. But if you have these types of areas of involvement supportive with your lab and clinical findings, you know that you're dealing with herpes encephalitis. But besides these two, rest of the viral encephalitis are typically non-specific. They can have a focal patchy involvement of gray matter, where basically the cortex asymmetrical on one side, that can support the diagnosis. Yes, that probably you are dealing with encephalitis, maybe increase the level of confidence if it is clinically present, may not be specifically pointing to a specific etiology per se. Then there can be the other etiologies which we have considered, like dengue or even cerebral malaria, rabies. In these scenarios, actually you are clinically reasonably sure what you're dealing with, because the symptoms or the clinical findings are totally different. The role of radiology is not to make a diagnosis, but to evaluate the extent of involvement. It may be required for prognostication, which all areas are involved, whether they are exactly correlating with your clinical symptomatology, and the severity of involvement of those areas, whether they've become necrotic to start with, the extent of involvement, that actually helps in overall prognosis of the patient, whether or not the child is likely to recover and to what extent it is likely to recover. In most of these, even in dengue, we can have actually extents of multiple hemorrhages also. Even non-hemorrhagic encephalitis is well known, but extent of hemorrhages can also be seen in dengue encephalitis. Then we can have actually ADEM also. So that, since it is a differential of your AES, ADEM is a differential, that in that place radiology can play a role. We all know ADEM has certain specific radiological findings, although non-specific findings are also seen. But if you see bilateral typically asymmetrical, predominantly white matter lesions in the subcortical white matter, typically larger lesions, may also be involving brainstem or the deep gray matter, symmetrical or asymmetrical. Then you can actually at least suggest there is a strong possibility that it may be fitting into a ADEM. If it is being clinically suspected, then again you can start the treatment accordingly if required, if the radiology is supportive. In this particular case, sometimes giving contrast also helps. You can see those typical enhancing patterns of demyelination. Then in terms of even bacterial, as we've said, TB can also be a cause. We all know how to see TB meningitis. It is far easy, and in our clinical practice, even TB can be not just basal. That's what I want to highlight. We've seen lots of, obviously, the typical basal exudates, basal meningitis, but TB, we've seen lots of cases of even peripheral cortical sulci also getting studied with TB exudates and not necessarily present in the basal exudates. Even that, based on the radiological picture of T1, T2 and contrast enhancement, we can reasonably suggest that it is fitting into a TB meningitis type of a picture also. In terms of autoimmune, we all know radiology can be significantly normal in many of these patients. So a normal radiology does not rule out autoimmune. As high as up to 50 to 60% of patients, maybe 70% of them will have a normal radiology. MR can be typically normal. But depending upon the time, like the characteristic NMDR encephalitis we see, it's again, most commonly it is the involvement of the temporal lobes. So bilateral symmetrical temporal lobes involvement, maybe extending to other limbic areas, and maybe with some involvement of the basal ganglia can give you a clue, yes, that if you're clinically thinking some terms of autoimmune, this may be fitting into autoimmune. But again, I've stressed upon a normal MR does not exclude autoimmune encephalitis.
Thank you, Atin. Yes, Salim. Yes, sure.
We certainly thought that HSV and ADEM are the two most recognizable neuroradiological syndrome as such. So we challenged 3 neuroradiologists, not essentially randomly picked, but we picked them whom we thought were the best neuroradiologists in London and showed them the 50 scans that we got from the study of ADEMs and HSV diagnosis. And you would be surprised that the agreement in the ADEM amongst the 3 was only 30%, and in HSV it was 70%. So I think for me, I think it's easily understandable from ADEM, because I think ADEM can mean different things to different people.
I fully
Number
agree on
one, I think ADEM diagnosis, even in the international pediatric MS, study group, it is not MS. So there's no real sort of actual definition of what ADEM is. And if we do sit down and put it down on a piece of paper, what that is, and I think that's still work to be done there, then the agreement will be much higher. And what I would use is the original description by Sylvia Tenenbaum in Argentina of all the different patterns of ADEM, and some of which is actually a description of Japanese B encephalitis, the deep gray involvement, ADEM changes.
So yeah, involvement of deep gray matter in isolation would have both differentials.
Yes, and we have some literature which says that temporal lobe involvement in Japanese encephalitis. So, it's going like that. Anyway, now the next question is to Dr. Lalit Dar. So what are the recent advances in laboratory investigations to identify etiological agents of AES, now including RT-PCR, serological tests, and viral isolation? Dr. Dar, please.
Yeah, thank you. While the definition of AES is wonderfully elastic, it covers a huge etiological range, seasonal range, geographical range. It's a bit of a nightmare for the lab. What I would request is that when clinicians are asking for investigations in these cases, they should keep in mind that they should not send requests under the umbrella of AES. Some narrowing down would be very useful for us as lab people. And, keeping that in mind, in India we have specific challenges. One, as Dr. Gupta has already pointed out, the etiology, unlike what you see in the West where HSV predominates, is not what we see here. In fact, when I started out in virology 25 years ago, we thought we used to culture the virus, HSV, we used to put up cultures, and we thought, okay, maybe the sensitivity is not good enough. We switched to PCR over the years, switched to real-time PCR. It doesn't account for more than 5%, at least in this part of the country, and perhaps even in India. So that brings us to the issue of looking for scrub typhus, which I think is a very, very good suggestion, and I think we should not believe that it is restricted. As you have seen, it's there in Eastern UP, which was a predominantly JE, affected area, in a larger number than JE. In fact, in 2014, from the ICMR data I saw, they saw about 20% was due to scrub typhus, and it went up to almost two-thirds of the cases by the time we came to 2016. So other areas, Chandigarh has reported a lot. In Delhi, we see a lot of scrub typhus, and even from the south, there are reports. I think it is prevalent in many parts of the country, and we should keep that as a priority. Etiologically, the other thing that we see is, of course, dengue, and therefore we have to keep in mind the seasonal variation. So which time of the year you encounter these cases is very important to see. If it is in the monsoon season or during the rainfall, please keep in mind that dengue, even chikungunya, has neurological manifestations, and these can be important causes of AES. So, with this, then I will go on to mention some of the tests that can be done. Of course, IgM ELISA has been used extensively for many different pathogens. So along with the CSF, a blood sample is desirable. It's not always possible to demonstrate IgM antibodies in the CSF, and even the presence of IgM antibodies in the blood is considered good supportive evidence in cases of Japanese encephalitis, in cases of dengue. So I think that is one important message. The other thing is that if you are, for IgM ELISAs, we have to have a wide range of assays available. So again, if you narrow down the diagnosis, it helps us. Among the new tests, the real-time PCR has picked up a lot over the years. And, that is one method which gives us a chance to match the elasticity of your definitions in the lab. Because then all we need is a set of primers and probes for each of the organisms that you are considering, and we can attempt a diagnosis for you, provided you give us a sort of narrower spectrum to look for. So that is a big advantage of real-time PCR, added to its sensitivity and specificity. What is coming up now is these array-based tests, which give you a sort of buffet of microbes to look for. Keep in mind that these are often designed with specific purposes. There are FDA-approved arrays available. Many of the arrays in the Indian market today are not FDA approved. Some of them are CE, they have been endorsed by CE, but definitely not FDA approved. But there are some FDA approved assays in the market. Some of them have stalls here, you may have seen. Now the point is that even the FDA approved one, I'll just give you an idea. It includes meningitis, and it includes encephalitis. So you'll find you have all the common pyogenic meningitis pathogens there. Neisseria, pneumococcus, Haemophilus are there. You'll find TBM is there, tuberculosis, mycobacterium is there. You'll find Cryptococcus is there. Some of the viruses are there, HSV of course, varicella zoster virus, which we again find in about 5% in our in our institution. That is there. But what is missing there? Measles, mumps, dengue, chikungunya, West Nile, Zika, Nipah. The list is endless. I mean, you have in India Chandipura, we've had outbreaks of CCHF, Crimean Congo hemorrhagic fever with CNS manifestations. So just even these arrays, although they offer part of the solution, do not give you the complete picture. And many of them still have issues of LOD, although the FDA-approved ones have good limits of detection. So lower limits of detection and sensitivity, specificity are good. The next thing that is likely to happen is point-of-care assays. We already have GeneXpert widely used for tuberculosis, recommended by WHO. the same kind of technologies are also venturing into other microbial infections. So I think at some point of time, we may see specific point of care assays. But again, narrow down the diagnosis is my last message. Thank you.
Thank you. Anyway, then the next question is to Dr. Akash Srivastava. Doctor, can you share the NCDC experiences on investigation of acute encephalopathy outbreaks of non-microbial origins, like we've had recently?
Good afternoon, everyone. And thank you for the question. I remember when I joined NCDC as a young epidemiology-trained officer, I was the foot soldier of NCDC, walking across villages of my country, trying to understand how environment has a role to play in the disease dynamism in infectious diseases for outbreaks. At that point of time, in India, what we call AES outbreaks were largely JE outbreaks. Most part of India, it would be JE outbreaks, except for in the central part of India, states like Telangana, Nagpur region of Maharashtra, and East Gujarat. There was another agent known as Chandipura virus that was emerging at that point of time. But I remember NIV was the only laboratory in the country which had the possibility of testing it. So if the samples would reach NIV, it's when we'll get to know that there's another etiology. Time changes, 2006, JE immunization comes in, and the country starts immunizing the people. The JE contribution to AES starts to decline. But the numbers of AES do not decline everywhere. And one such story is from the state of Bihar. In the state of Bihar, if you divide Bihar into two parts, the South Bihar and the North Bihar, the story in Gaya districts and neighborhood districts and bordering Jharkhand, it's a typical JE story. But something is different what is happening in northern part of Bihar. If in South Bihar, it was after August, when the rains had happened, the vectors were multiplying, and you were having JE. That was not the season when the North Bihar was getting affected. The North Bihar was getting affected in the month of May, picking up in June, and finishing by July. So as soon as the rains would onset, the outbreak was over. How old was the problem? Very, very old, I believe. But documentation, 1995. 1995, Chief Minister Bihar addresses the Legislative Assembly of Bihar saying something serious is here, we need to seek help of the central government to come in. So I can say documentation, 1995, but problem probably even longer. Many institutions, NCDC, NIV, many of the pediatricians present here today have also investigated Muzaffarpur. And a lot of information was started to gathering because of all those investigations, but nothing conclusion was coming up. But one thing was certain, that microbial investigation was not resulting in anything. There was no JE positive cases in every investigation that happened. And then when we had good labs in NCDC, good labs at NIV, other microbial agents were also tested for, but nothing was coming out. Entomological investigation, ICMR institutions like from Madurai, NCDC entomological teams investigated the Muzaffarpur. Muzaffarpur is actually a North Bihar district, and some of the neighboring districts of it, like East Champaran, Vaishali, Siohar, Sitamarhi, bordering districts also have some contributing cases to that. But there is a medical college in Muzaffarpur that makes it a point where most of the cases would come in. But anyhow, so entomological investigations, they were not supportive of the JE etiology. Specimens for pig were being collected, sent to laboratories, ICMR institution, there's an NRCE, National Research Center of Equines in Hisar, tested, nothing supporting for JE. So this question remained unresolved. To resolve that, NCDC was assigned this task in 2012. In 2012, somewhere in May or April, in Lucknow, there was a large get-together of a scientist consortium, and they agreed that as it is not a vector etiology problem, NCDC should take care of that. Unfortunately, in 2012, we had 2 postgraduate courses running in NCDC. We had a master's in public health. We also had a new launch Epidemic Intelligence Service with collaboration with CDC. So we had some good number of people to investigate into this matter. And then we sent those teams, stationed them at Muzaffarpur. And in Muzaffarpur, first we did a scoping for the 2012 data for the whole year. And then we got some information that made us to decide that in 2013, we'll have a prospective hospital-based surveillance in which the team will be stationed much before May. And they were stationed in Muzaffarpur. They collected clinical data of all cases that were admitted in 2013. In 2013 data, what did we understand? We realized, before I go to the clinical, there are two important things that I would like to, again, other than one, the seasonality that I mentioned, another thing that I would like to let you all know is that in this country, if there are 500,000 megatons of lychee production, then 215,000 megatons of lychee is produced in Muzaffarpur. So it's the largest producer of lychee in this time. So that's one information. Anyway, so what did the clinical information tell us? The clinical information told us that these are children, all less than 15, most of them less than 10, and the majority, the bulk, is less than 5 years of age. Second thing, in clinical presentation, fever was not found in recorded at the point of time of admission in a large number of patients. So in AES, the fever component that we talk about was missing out here. But seizure was there, altered sensorium was there. Seizure means generalized clonic-tonic seizure, and altered sensorium means the typical presentation is that the child
Dr. Srivastav, we'll have to hurry up a little
Okay.
bit, please.
Right. So let's finish up. So the presentation showed us that there is an altered sensorium which quickly leads to coma, and the child has a death within 24 hours to 48 hours. Then we went into the blood and serum examination. There is hypoglycemia. CSF is unremarkable. MRI findings are unremarkable. EEG findings are unremarkable. So we had to do a finding of field studies and identify what could be the other reasons. The other reasons that we had to investigate was possibility of first ruling out microbial etiology, for which 40 specimens of CSF, 40 specimens of blood were sent to pathogen discovery lab in CDC. They did a pan-viral generic metagenomic assay and also ruled out any microbial erosion. The second thing was rule out role of pesticides. Two institutions, the NIOH from India and CDC, they ran a scope of studies. Neither were pesticide residues found in food, water, vegetable, and fruit specimen. Neither were tests like cholinesterase assays that were done in the specimen, in the patient's blood, found to be abnormal. Ruled out role of metals. A battery of tests for 25 metals was tested in blood, urine, no metal etiology. Last was the possibility of a plant toxin. In plant toxin, why were we suspicious? Because something had happened called Jamaica vomiting sickness. In 1980s was reported from West Africa and West Indies. Ackee fruit poisoning was reported of a similar picture. Therefore, we suspected that. Now, to move on with that, we needed 4 things to happen. We had to demonstrate that there was a poison in the
We'll
fruit.
have to finish off
Yes.
now. Sorry. I'm really sorry.
Okay, thank you, Dr. Srivastav. And actually, after listening to the definitions, the etiologies, the differential diagnosis, and for the investigations and all those details, I think management of AES cases is the most critical,
yeah,
the crux of the matter, and I would.
I'm going to cover that. So actually, I don't think we can have a management guideline which is common to the whole country. India is a huge country. We have different etiologies in different parts of India. So management guidelines will be different according to what is seen in that region. And different centers have to take their stock of their own situation and go on from there. So for example, in some case, in Assam, JE is the dominant cause even now. In others, it is herpes, and in some areas, cerebral malaria is very important. Scrub typhus is re-emerging in Uttar Pradesh, and then there are reports of leptospira and all that. So, what we have done in Lucknow, because we get these, our most important things are JE, dengue, rickettsia, then maybe lepto, and maybe some herpes. So this is what we are seeing generally, apart from bacteria, etc. So now, so what we do is, we do complete blood counts, which includes a platelet count. Then peripheral smear and a rapid malaria test for the simple reason that although malaria is not, falciparum is not endemic there, but it's such a treatable cause. So if there's even a small chance, we treat it. Then blood culture and Vidal we do. Then blood chemistry with glucose, electrolytes, and urea, creatinine, and full liver function tests, including even INR. Then CSF for cells, protein, sugar, culture. We also do JE, IgM in the CSF, and PCR for herpes. Then in the serum also we do virology for JE, the IgM to dengue, NS1 antigen, IgM to rickettsia, and now IgM to leptospira also. And finally, imaging when the patient is ready or can be sent down. Sometimes they're very low and they cannot be sent. So this is the kind of investigative workup. Then the management is really divided into two, the supportive management and the specific management. Now, supportive management is common to all AES. First of all, the recovery position, IV fluids to maintain homeostasis, then antipyretics, if there's fever, anticonvulsants, if there are convulsions, measures to reduce intracranial tension, like elevation of the head end, mannitol, 3% saline, furosemide, glycerin and acetazolamide, and finally even mechanical ventilation. Then nursing care, of course, like chest physiotherapy, changing the position often enough, care of the eyes, skin, care of the bowel and bladder, and the nutrition of the patient. So this is all the supportive care which is common to all types of AES. The specific treatment, we actually give ceftriaxone to everyone because we are not very sure. Actually, they're critically ill patients, and even a secondary infection may tilt the balance against the patient. So that's one reason. And secondly, before the bacterial cultures come, you're not sure that it's not a meningitis. Now, secondly, for herpes. Now, herpes is the only viral agent for which there's a definite treatment in the form of acyclovir. Now, the dose for children has actually gone up. It's 15 to 20 milligram per kg IV every 8 hours for 14 to 21 days. So the dose and the duration both have gone up. And if you are suspecting non-response or resistance or relapse, you go on to Foscarnet, 100 mg per kg per day in 2 to 3 divided doses. Now, whether to give it to all AES, as is done in the West, that's a big question. Now, it depends on what all you've got. So we've got so much of other things that we don't treat everyone for herpes. So we only treat if the patient is coming out of season. That means it's not in the post-monsoon season. If it's coming in, say, February or March, then you think more of herpes. Or if there are focal deficits, or if there's a suggestive MRI. So so that's about herpes. Now, for Japanese encephalitis, there are trials only, and the first trial is done in 2003 by Solomon and Roll, and they used interferon alpha in 112 Vietnamese children with suspected JE, out of whom 87 had serological confirmed infection, and there was no benefit. Then we ourselves did a study in 2005 to 2008 with ribavirin, and that again, there was no benefit. But it just, people were giving ribavirin empirically, so that discouraged the empirical use of ribavirin. That's what the study did. Then in 2012 onwards, we did a trial with minocycline, which I'll come to later. But minocycline was done in animal studies before, in which there was complete protection against Japanese encephalitis. So this is done by the National Brain Research Center. So this is about GE. Then the third thing would be scrub typhus. Now, scrub typhus, we give doxycycline, which can be given, it's usually available as a tablet. So you have to crush the tablet and give it through the nasogastric tube at a dose of 5 mg per kg body weight. in 2 divided doses for about 7 days. And sometimes there is an injection also available. So injection is given as 100 milligram twice daily in 100 ml of normal saline over half an hour. And then azithromycin can be given, IV or oral, 10 mg per kg body weight for 5 days, once daily. So this is for scrub typhus. Now scrub typhus suddenly jumped to so much importance that there was a directive from the Ministry of Health and Family Welfare, Government of India, to the Government of Uttar Pradesh, that please give every child coming with fever or AES in the Gorakhpur region, please treat him with doxycycline. So this is what is being done actually, even at the primary health centers and all, they are treating. They have this directive. I don't know if the quacks and all are treating, but the government doctors are. So then we come to, then you also have cerebral malaria. The recent data shows that intravenous artesunate actually is preferred, now is preferable to artemether or quinine. Artesunate is better, okay, IV artesunate. Then, so the dose and all, of course, I'll skip over here. Then you also have influenza as a cause of AES actually. So even the swine flu occasionally does cause AES, and it can be treated with the seltamivir. There's a drug called plicoranil, which is used for enterovirus. But it's still awaiting trials. They aren't enough, it is not yet recommended. Now, the last thing is about AES. We did a study with minocycline and AES. Okay, now this study had adequate sample size, 281 patients, and we did find there was a trend towards benefit. There was a definite trend towards benefit. And then what we did, there was the p-value did not reach significance, it approached significance, okay? Now, we took 3-month mortality, cumulative 3-month mortality as the outcome. And also the Glasgow outcome scale at 3 months. So in both these parameters, there was a trend towards significance. Then what we did was, and this trend was accentuated if you just remove the children who died on day 1. So lots of children come and die just in a few hours. So once you remove them, because they're already moribund, you can't save them with 1 or 2 doses, so you just remove them from the analysis, then this trend was significant for the 3-month sequelae. And it approached significance again for the 3-month mortality score. So that's the gist of all the specific treatment we have for AES and all the trials that I know of.
Thank you, Dr. Rashmi. It was important. Quickly moving to Dr. Nivedita for her comments on preventive healthcare measures for AES, including immunization.
So if I talk from the public health point of view, we all know that vaccination and vector control are the key to prevention of Japanese encephalitis. For Japanese encephalitis, there is a live attenuated SA1414-2 vaccine, which is given by the government under the routine immunization, and this vaccine is imported from China. That is not available in the market. But there are 2 indigenous vaccines which are made by Bharat Biotech that comes by the name of Genvac, and the other is made by Biological Evans, which comes with the name of Jeev. So both these vaccines are available in the market in almost all states of the country. So whoever wants to get vaccinated can take these indigenous vaccines and get vaccinated. So, and of course the information, education and communication, that is community mobilization and engagement, is very important. In terms of the community should be made to understand what are the important causes of AES and how they can be avoided. And if I talk about the scrub typhus, so we have also done a study on the risk factor mapping of the patients who come with scrub typhus infection, either as fever or AES. So in the Gorakhpur region, we find that open defecation is the most common risk factor for acquisition of scrub typhus AES. And this is followed by Very strangely, we observed that this population stores a lot of firewood either inside their houses or in their verandas. So this leads to a lot of rodents harboring those places, and close proximity to the rodents which do have these mites on their body, which are the vectors for scrub typhus infection, were also found to be one of the major causes. So, and of course, at the level of the primary healthcare centers and district hospitals, it's very important that the clinicians are sensitized towards early referrals. We also have recommended to the state government to also incentivize the quacks and the traditional healthcare practitioners that are there. So probably incentivize them to make early referrals whenever they see any alarming signs. So all these efforts are being made from the government, and even ICMR has recommended presumptive treatment with doxycycline during the high transmission monsoon season to all the children that present with fever in the high risk areas wherever we see transmission of scrub typhus. So, and we also feel that it's very important to do fever tracking. So whenever a clinician sees a fever patient, they are advised some tests. And in that battery of tests, if you find somebody is negative, you just say that this is not dengue, this is not scrub. But please remember that whenever you are going for an IgM ELISA, it will take at least 4 to 5 days for that ELISA test to become positive. So what is the duration of fever? And that is very important to advise the right kind of test. If in a patient of less than 5 days fever, you advise a dengue IgM, then definitely we hope that it will be negative, and then that patient will be wrongly labeled as dengue negative. So the right choice of test is very important. And lastly, I would like to say that I have in front of me a list of 12 to 13 infectious pathogens. If you look at the last 10 to 15 years, data from India, various surveillance networks, published studies, then there are 10 to 12 pathogens which are predominantly causing AES in our country. They are all viral, bacterial, as well as fungal. So it is very important at the level of, if IAP can take that task, it is very important to develop very strong clinical algorithms so that whenever you see a patient of AES or for that matter acute febrile illness, how to suspect leptospirosis and advise the right kind of test, how to look for scrub typhus, how to look for Ishar, how to look for rash, and then advise the right kind of test. So a simple flow chart starting from the clinical presentation, blood picture, and then what pathognomic signs and what would be the right test to advise. So as Dr. Lalit Dar said, that if the sample comes with a label of AES and the laboratory person is expected to give a diagnosis. So then in that, lot of pathogens get missed. So if the clinician could pinpoint through the clinical algorithms that what could be the possible etiology, then it actually also enhances the detection rate and catching the etiologies which are at least treatable so that the patient can be saved. That's all from my side.
Thank you, Dr. Nivedita. We are running out of time. Just to quickly conclude, actually, a lot is being done to, by the government agencies, the National Vector-Borne Control programs, and, UN agencies like WHO, UNICEF, PATH, and Tata Trust, and so many other NGOs are involved in, community sensitization, management, training, capacity building. And a lot is being done with a, objective in mind to reduce CFRs. And I would like to thank the panelists, but before we close, I think we would throw it for any questions, any burning questions you have for the panelists.
Just in time.
I think no questions, so we close it here. Thank you very much.
I wish to put on record, we thank PATH India to have supported this session. Thank you.